So I have the pleasure today to interview my friend Jan Belohlavek from Prague. Jan is cardiologist, critical care physician, and of course today I choose the topics probably you like the most, ECPR. So Jan, thanks for being here. I start with the first question. I prepare like a journalist. So the first question is, ECPR has moved from experimental rescue therapy to something that some systems consider to be like standard of care. So the first question would be what we truly know about the benefits and what remains uncertain.
Yeah, so we need to define what is a standard of care. I'm not sure about that exactly, but what I know after 15 years of doing ECPR is that it works. However, it works only in a certain specific way how you perform your all CPR, how your system works. So this is not just about putting a patient in an emergency cardiac arrest setting on ECMO. It's about your pre-hospital, if we are talking about out-of-hospital cardiac arrest, then how is your pre-hospital system? How is your alertness in the general population? How people are available for bystander CPR? This is everything in one piece of work. And the problem with ECPR and the outcomes of ECPR, and for myself, the only good outcome is when the patient leaves hospital awake and is able to return or almost to return to his whole life before. It means that if any part of this chain fails, then your patient is not going to reach that outcome. So it's not just about whether we have to discuss should it be or should not be. It's about whether your system of care in your city probably is available and is prone to start with this very advanced intervention. And what we also know that to be good in whatever you do, interventional procedures, you have to do it often. So unfortunately, it's not for everybody, it's not for every city, it's not for every operator. It's for a large, high-volume centers and for a really well-established systems of care.
Yeah, I understand. I think it's important if you can help the people that will listen to us how to interpret the three randomized clinical trials that are present in the literature. And we now have this pro-con debate at the Congress, and there are conflicting results, at least at the first sight. Can you help people to understand them?
Yeah, it's very easy to interpret those three trials. So the first trial, the ARREST trial, I guess published in 2020, Lancet, it's a trial that actually has proven in a randomized fashion what we knew for years. And that is that if you want to bring your patient under ongoing CPR to hospital and try to get a reasonable survival, you have to put him on ECMO immediately. Otherwise, if you continue conventional CPR after 50 minutes of failed pre-hospital CPR, there your chance for survival is approaching zero or is very negligible. So that trial was a small trial, as you know, and actually was stopped, at least how I understand this trial, and maybe in a hot phase, well, you're a trialist. What a hot phase of the trial means, it means that within the first part of the trial, anything may happen, and if you kind of use your statistical, games, then you can get to the. I'm not criticizing the trial. I'm just saying that there is much more that you need to know when you deal with a trial with cardiac arrest. So this is the first trial, but this trial opened the gate and has shown definitely that there might be a reasonable survival for patients after prolonged CPR, and that's important. The second trial was our trial from Prague. That was completely different. The question was completely different than from the Minnesota because we randomized our patients in the field. So our question was, if you have a patient with a refractory cardiac arrest, and we can discuss this definition based on our trial, it was basically 15 minutes of unsuccessful CPR and any rhythm, because we enrolled patients with all rhythms presenting, then is it better to take the patient to hospital for eventual immediate ECPR, or is it better to stay on site and play and wait for ROSC? So what our trial has shown, and the trial, because it was a very explanatory trial based on a classical statistical, approach was by definition negative, but I don't consider our trial negative. Our trial randomized patients in the invasive group, and those patients have been resuscitated for 61 minutes. And as you well know, those patients survived well with a good neurological outcome with 32%. So it's an excellent result, basically. And that's what we expected. What we did not expect was a favorable outcome in 22% of patients in the standard group, where we presume to have 10% of survivors based on the prolonged CPR for 45 minutes in the standard group. What happened there? Probably a good system, probably the crossover played a major role, and we can discuss that later because this is important for the cardiac arrest studies and for the ECMO studies as well, generally. And what I think is that if you implement such a complex, invasive, coordinating, logistically demanding approach, then you increase the level of standard of care, definitely.
Can I also add a point? The two trials that you mentioned were single-center study, because you really said at the beginning, it's not something that everyone can do. That requires high level of care pre-hospital, but also someone who is very skilled. So that's also very important to mention.
So that's why I'm saying that those were explanatory trials. So the trials in the best possible scenario, trying to show that the intervention works. That's how you do the science. And then the third trial, the Inception trial, was a multi-center trial when investigators just said, okay, let's start to do it. They enrolled 10 plus centers who were ECMO centers, but not a specialized cardiac arrest centers, not a specialized ECPR centers. So to become a successful ECPR center, first you have to be a large volume cardiac arrest center. So you need a lot of experience with cardiac arrest patients. So for example, our center has about 150 cardiac arrest cases per year. Then you have to be a high volume ECMO center to be able to care for all ECMO patients. And at the end, the third, you need to do ECPR, which is kind of a cherry on the cake of all the system. So it's not easy. And therefore, I think that's why the trial failed. And why the trial failed, the Inception trial failed because they were too slow. They just did poorly. It's a race. It's a race for the win. And if you are racing and you are slow, you're not going to win. So that's how it is.
What you said is very important, because I think that most of the people will read the abstract of the paper, the main figures, and they will try to put this trial together. And I think you pointed out, arrest, you arrive at the hospital on ongoing CPR, 40 minutes, and then if you do nothing, 0% survival. Your trial is, I decide on site to transfer for ECMO or not. And the third study is, I try to do it whatever, large number. So can this be generalized to all centers that are supposed to be part of these large communities? And the answer is probably not. So I think it's important when you mention, because we tend to put these three trials together, but they probably did not study the same study question, the same hypothesis, and not in the same setting. So that's very important. Thanks for that. Now, imagine that people who are listening to us would be still interested, because they are good cardiac arrest centers, they have good ECMO centers, to implement what's over ECPR. So the question is, if you have to give an advice, which will be the good candidate? Which will be the candidate you will start with in that population? Well, you will be rewarded because there will be a little bit more survivors than doing in all cardiac arrest victims. I'm talking, of course, about mainly out-of-hospital cardiac arrest.
So per my understanding from hundreds of patients we had, the best candidate are those patients who have intermittent ROC, so who have a refractory VF, patients who go there and back with a ventricular fibrillation. Then you defibrillate, they've got a rhythm for maybe a couple seconds, maybe 1-2 minutes, and then they go back again to VF. Those are the best candidates. And the reason is not just the way that they have intermittent ROSC, so this kind of a pre-conditioning, post-conditioning thing, but usually have a cause that can be fixed very fast. So those are the best candidates. And in those patients for past 13 years, and I'm talking about VF patients who come to our hospital undergoing CPR and they keep VF on admission, we have a substantially same survival, around 40% of patients coming in this condition. And this is important because pertaining and remaining in VF means that your metabolism in myocardium is somehow sustained, means that your CPR is probably good, and that's what we are just now scientifically working on, looking and analyzing how the metabolism of the myocardium works, and it's kind of a similar like ETCO2 showing what's going on actually.
What do you think about this concept of signs of life? Are also these good candidates?
They are perfect candidates, yeah. To be honest, absolute majority of our patients who did have signs of life on admission, they survived well.
Okay. Now, I'm very puzzled because when I asked you this question, you didn't discuss a lot about no flow, low flow, whatever, which is to me very interesting because in a real life, you will discover that what has been considered to be the no flow of 1 minute sometimes become 5, 8. No number changes. It's a so stressful situation. So, are there any red flags? So you mentioned which is the best candidate. I understand. You didn't mention the time. I think it's a good information for the people who listen to us. What about the red flags? Those patients who the chances that ECPR will add anything is extremely low.
Yeah, Fabio, after doing this, there is one mystery. And the mystery is that when you admit those patients, when you look at them the first time after 40, 45 minutes of CPR, it's so difficult or almost impossible to predict what's going to happen. So that's the reason why we stopped using laboratories to decide whether we, proceed with ECPR or not. But of course, the time matters. And if you have a patient with long no flows and very poor, resuscitated low flows, those patients do worse. But the problem is you always work with the information you have available at the moment you need to decide. And usually at the moment you need to decide, those informations may not be available completely, or they become available a couple of minutes later, and that's, late. So
is it possible in a center like yours, with so huge experience, I would say you have more a tendency to treat more, which means if I have a doubt, I will treat, rather than I will find all the limitation why I should not implement it. Because most of the experience center, they tend to treat in doubt. They over-treat some patients that will not be treated in other centers. Is it what you do, or you try to keep really only the good candidates?
I wouldn't call it over-treatment. Our treatment is a little different. I would call it liberal approach to use this intervention called ECPR. And there's been a nice study from Denmark showing that if you have a liberal approach, you have a relatively lower survival, but in absolute numbers you have more survivors compared to restrictive, when you have a high percentage of survivors, but the absolute number is low. And that's exactly the point. The point is that we are quite liberal to use ECPR, but we are very strict later, and that's what you might like, to do early neuroprognostication, to immediately try to identify those patients who have no chance for survival. So I can disclose we are running a trial now with a very early neuroprognostication, including SSPs, including EEG. We're able to perform 1, 2, 3 hours after cardiac arrest immediately when the patients are being admitted to ICU. So, and this trial will compare the 24 hours early neuroprognostication versus the routine neuroprognostication based on the guidelines. And our first, signal is that we are able to neuroprognosticate 24 hours after the cardiac arrest. And that's the point. The point is identify those who cannot benefit from the intervention and stop the care or withdraw the care.
There is also another aspect. Many people, you mentioned the expertise, you mentioned the system, you mentioned the selection of candidate. Of course, everything would understand that the fastest you go to perfusion, the better is for the patients. Well, that's one of the idea. So what's your opinion about those systems that are trying to absolutely implement pre-hospital cannulation. And I'm not only talking about, we know the experience in Paris with a very nice picture of Lionel Lameau, but also now this study we are waiting for from Netherlands, where they go with helicopter putting the ECMO on site. Of course, I don't think the study is being just published, but what's your opinion? Is that something that is definitely better, as people claim, or it's again is system dependent?
I think so far we cannot say it's definitely better. There is no randomized trial looking at this, and there is even no larger series of patients suggesting that might be better. But there is some rationale in that, and I have to admit that we have been thinking about that for years, and we started to do pre-hospital ECPR as well in Prague. So we do have first year of experience. We had plus minus 15, 16 cases, and our very, very initial experience is that really the times may be shorter. Whether this shorter period of the no flow plus low flow will transit into the better survival, we will see. But there is some rationale to do it. But I'm afraid those trials you mentioned will not answer the question, because this is very selective population. As you know, the Netherlands trial is very selective.
Absolutely.
And probably doesn't apply for all the patients that might benefit. And it's very costly and not cost effective. And the false rate of the alerts is very high. So we are working on the alert system. We are working on very early identification of those who might benefit, to keep the very specialized teams, not working, but to use them only if they are needed.
Okay. I would like now to maybe end with 2-3 questions, more general. One is, so we discussed about the intervention and the results of the trial. But of course, when you implement ECPR, I say just the beginning of problems. Again, practical message. Which are the 3, if you want, priorities for you in the first hours following the start of ECPR? Again, mostly talking about out of hospital, because this is where we have more literature, maybe more experience and more discussion.
I think the most important is initial communication with the EMS. So to establish a system how you communicate with EMS very fast, very efficiently, to prove the information you have to identify adequate candidates for ECPR. The second is a very efficient way how to get the ECPR team either to patient or patient to ECPR team under very effective CPR. That's also very important. And the third is initial, treatment. The cannulation experience, and this is really related to the operator and to the experience of the team. Good. And then the complex ICU care, which is very, very demanding, as you know, for the team. And also the team spirit is important. So I think a great role in the debriefing of the period. So therefore we have every second week we have a debriefing period with our nurses and doctors, covering different topics, including our patients, including the ECPR, the outcomes, and also the post ECPR clinic. So we have established also the post CPR ECPR outpatient clinic for the survivors, because it's those people survive, but they have plenty of problems. So what I'm saying in conclusion is that you need a system from the start to the end. And so you cannot just focus on cannulation and that's it. That's not how it works.
I will try to make a final challenges on some criticisms, because there are people who will criticize this. One first criticism that I heard a lot about is the equity of care, which means when you start to do the project in Prague, I presume you will not offer ECPR to people living 2 hours from the hospital. So we imply that there should be an inequity of care distribution. Is there something that you should just accept? We just say, no, guys, that's the only way to do ECPR. Is there something else we can do? We heard about the helicopter or whatever. And do you think that the solution of having smaller centers doing CPR, some colleagues said, I would like to do ECPR because everyone wants to put a cannula. Is it the good solution when we see what happened with Inception?
Yeah, this is our everyday discussion. So, you're right. This has to be addressed. The first thing is that I'm afraid in next years, it's our aim and our purpose to try to get this treatment available for as much as possible. The second point is it's probably not possible because of the time delays. But this is, this is routine in clinical medicine. Nobody doubts about the primary PCI for STEMI is effective, more than 90%. But look to United States, look to Canada, look to Kazakhstan. Still, many of people are treating with fibrinolysis, which has 60% success rate. So that's how it is because the distances are simply long.
Exactly.
So you cannot offer this to everybody. But I think you are a step ahead of what's going on right now. So we are right now running the European multi-center trial to try to show that ECPR works, first, and second, can be implemented in different areas, different cities. And if this trial is positive, then we have to start to think about the equity for everybody. And I'm still afraid that it's not for everybody. But that's how we develop the systems of care.
The last challenge, and will be my last question, is some people said ECPR requires money. You need to train people, you have to have available operators. These patients, if they survive, they stay long at the hospital. All this money that we use for ECPR could be used, for example, to increase the knowledge of population about conventional CPR. We will increase the number of people that will have a bystander CPR when they suffer from out-of-hospital cardiac arrest. So it's a matter of redistribution of money in the society. Again, it's a criticism. How would you address this point? Is it something that you think it's relevant? So conventional CPR should become before ECPR, and the two possibility can coexist into a system of care.
And that's definitely highly relevant because you cannot have successful ECPR program without a successful and well-established conventional CPR. So ECPR is just on top, this is added value on the very well-functioning overall CPR system. So as you said, alertness, bystander CPR, etc. So in Prague, for example, we have been working with our EMS system for 25 years to improve the bystanders. We have data for past 20 to 25 years, increasing the number of telephone-assisted CPR, bystander CPR. As you know, it's 80% in Prague, so it's pretty high, much higher than the other countries. It's similar to Scandinavians, etc. So this is really important. And then you can start with the advanced therapies, because if you don't have the basics, you cannot build, the advanced therapies.
This is an important message for, again, all the people who want to start ECPR randomly in one site, start to see which is the quality of the system you work in, and then ECPR will be, the additional step you can afford to your patients, but conventional CPR should be the starting point.
And the last remark would be, in terms of the money. Yes, this is expensive intervention, but compared to other, expensive interventions in clinical medicine, the survivors of ECPR, 50% of them return to work. And the remaining 50% who survive, they return to home. They are somehow, damaged. They have some problems, but they can live the full life. We are usually not kind of generating people who need advanced care later on. Those people don't have chronic heart failures. They don't have chronic organ failures. They are not on dialysis. They are not in the chronic, outpatient heart failure clinics for advanced heart failure. So this is the difference. So those people, end up with a very good quality of life.
Thanks, Jan. Really was fantastic to have discussion with you. ECPR is something we discuss all the time at the Congress, and having one of the worldwide expert here with us for 25 minutes talking about all the different aspects from the implementation up to ethics and money has been fantastic. So thanks for your contribution.
Thank you very much for inviting me. Thank you.